love to invite up our wonderful Integrative Strategies panel. Steve Overman is going to kick us off.
So, as I'm getting plugged in here, what I would like to do is actually not do some of the comments I was going to make. Acknowledge this morning, what did we learn? Pain is complex. We need to start with the patient and help them gain the confidence in understanding and managing. And advocacy in all forms is important. Now, we have a panel. We have a great afternoon planned. 2 people. What would you like to get out of this panel? Two hands. Anybody? Get us set up and get us activated? Come on. Come on. There's one. There's one.
I'd like to hear more about different alternatives for managing pain.
Okay. Another. Yes.
I was going to say, first of all, hi Steve, hi to everybody. And I was going to say actionable things that we can take home as advocates and do something with them.
Good. So I'm going to try to tee things up, get us on the same starting line, but I'm not immediately addressing those, but I have one slide that will be part of my sort of framework. So let me, let's see, so here's our panel. I wanted to have them up right at the out. Brad, raise your hand. Okay. Dora, you've met, and Garth, okay? So they will give you the specifics on, but as we all get to the same starting line here, the panel is about integrative care and healing and pain. So the question is, what is healing? So this was a build slide. It's not build. It's all right here. Which definition are we going to jump on? I think the idea of restoring health and getting well is what we've heard about. Really, that's the pain area, not the cure. As we think about, well, what does integrative mean? Well, it's a verb. We integrate, right? But it's taken on other meanings. So here we can see alternative. Well, let me just build them all out here. So it's kind of allopathic has traditionally been that which we do, medicine, surgeries, right? But also science-based. Now I'm going to use that and put quotes around it because then alternative was that which was not conventional. And historically was not science-based. Well, what have we learned about so far this morning? A lot of science, right? Well, then complementary means we're actually adding to, not instead of. And so we'll find that, in fact, down here, National Center for Complementary Integrative Health, that used to be complementary and alternative medicine. So even they've changed the name nationally. So as we move towards integrative, I think what we're learning here is it's not only complementing with our therapies, but the role you all have in helping us, the patient, the families, integrate. That's the hardest part. Okay, so, and this is an old joke that I had down below those. It says, I'm giving up spells and going into behavioral modification. Surface a little science, change the name, and we got the same stuff, right? And that's, I think, what we're going to. So, before the National Institute changed its name, this is how they broke down complementary care, just to give you a framework, okay? So it had mind-body, biologic, body-based. We're representing, in a sense, those 3 areas of the panel right now. We don't have we're not going to do energy medicine. I heard some conversation around that, right? Reiki and so forth. Spiritual care, important. VA has some programs in that area. And whole systems. What's a whole system? Ayurvedic, for example, Chinese medicine. With that perspective, then they said, well, what are the different strategies? And I won't go through all these. We've heard of some of these. This is what the list, the list has looked like in the past. Special diets. Is that alternative? Is that, No. This is just the way it's gotten listed, and now we're trying to embrace non-medicine, right, non-procedural care. What have we done for? Again, we've heard. But if you look across the bottom, you can't see back pain, neck pain, joint pain, arthritis, anxiety, cholesterol, colds, musculoskeletal, severe headaches, and insomnia. 8 out of the top 10 reasons really are pain and pain-related. And that's why we're here. And so then here's my one perspective, okay? So I was in the office, and as Dave pointed out, without a lot of time, how did I try to conceptualize this? And this was my framework, really, that I've developed, taught physical therapists, and have been interested in. 5 components of pain, if you think about. Movement and balance. We've heard about how, asking a patient, how did or does movement aggravate or help your pain? whether it's relevant, you got chronic sensitization and fibromyalgia, it's still an important question because that's part of the framework, right? Secondly, inflammation. That's where I spent my life as a rheumatologist. So much inflammation that we don't know about that gets undiagnosed, but what's the question? Do you have stiffness or heat? Does diet or do those doses of anti-inflammatories affect your pain? You can have all this brain pain, but if we still have positive responses in those areas, we have to talk about it. We have to put that as a part of the model. It's important for everyone. Nervous system, we've heard about that, right? Sensitization. Well, what are the nervous system disorders that we know it really gets out of whack? Peripheral nerve, who's heard of post-herpetic neuralgia, right? Fibromyalgia. And yet underlying those are inflammatory issues many times. I mean, it can be a triggering event. So we talk about nervous system. The next one, hormonal balance, is my way of saying the stress system. Well, what is that? The autonomic nervous system we've heard about. And I put it under hormonal and ask questions like, have you noticed how your fear reactions or frustration affects your body or your pain? And last but not least, we call emotional balance. That's what I've called it. We can call it cognitive, but the issue is, does your pain worsen when you have certain thoughts or memories? The only reason I put this up here is, for me, this was a simple construct for me to try to keep my mind open to everything we've heard this morning and feel that every person who came in with pain beyond the acute emergency room visit, okay, persistent pain of any sort, not until they've got chronic pain 3 months, 6, every person deserved to be heard and evaluated in each one of these domains on a regular basis and try to understand and diagnose elements that we miss and then put it together. So, here's some questions that I posed to the panel. This is the tee up. Get your pencils out. Start writing down your questions. I will pass it on to them to introduce you to some of their perspectives, then we'll have a good discussion.
Hi, everyone. My name is Brad Lichtenstein, or Lichtenstein, or just Brad. So I was taking notes this morning. I'm an associate and clinical professor at Bastyr University, and I also have a private practice called The Breath Space. I was here last year, if anyone was here, talked about breathing. And I've been teaching at Bastyr for 20 plus years. It's so weird after it gets to 25. And I've been teaching in the counseling and health psychology department. I also taught their spirituality and counseling classes. So when we talk about spirituality, it's always interesting to me. NCAM, the older version of the National Center for Complementary and Alternative Medicine, just put spirituality as one of the modalities. I think everything we do is spiritual, because one of the 8 definitions of spirituality is finding meaning and purpose in life. And that's what we talked about. You heard about that. So for me, when I work with patients, the very first thing, all the patients that come to the Bastyr Center for Natural Health and come to my mind-body medicine shift, or in my private practice get, is a vision statement. I give them vision statement homework. I ask them, how do you want to live? Now, I began my career in HIV care. And so back then in the 90s, most of my patients had a 2 to 5 year life expectancy. And so when I was working with patients, this is digressing but connecting a little bit. When I was working with patients, you know, the biochemical stuff as a naturopath, we talked about herbs and nutrients and all of that. We didn't know a lot about everything back then, but that biochemical part took 15 minutes. But why I like naturopathic medicine and why I went into it, I was going to go to University of Chicago. I got in for an MD, PhD program, but I went to Bastyr because we had an hour and a half for a first office call. I still see patients for an hour. And so when I talk to my MD colleagues and other colleagues, they say, oh, well, you know what I could do if I had an hour? Yes, I do. So it really, to me, I want to know the person. As William Osler said, I believe he said, we treat the person who has the disease, not the disease. And I know I'm preaching to the choir here, but I'm going to talk a little bit, just briefly, about some of the things that have already been addressed. You know, I was also the chair of our homeopathy department and study Ayurvedic and Chinese medicine, so I have a perspective about this, but all my students learn in our behavioral medicine classes about ACEs. So people have talked about ACEs, adverse childhood events. Because when you look at adverse childhood events, events that happen early in life, They impact your neurodevelopment. So the words I say, whether this is completely accurate or not, is I say the nervous system is the master regulator. I don't work with disease. I don't treat insomnia, back pain. I treat the nervous system. And it speaks to how you're orienting. So first, patients get a vision statement. And many people say, well, how do I want to live? I don't want to be anxious. Like, that's the negation. What will that look like? And it's amazing how many people cannot fathom that. So something I explain to every patient is something called the Polyvagal Theory. Has anybody heard of that? Yeah. So several people have. I always talk about this, and there's some debate about this, but we could talk about this, but I give them this framework because something happens miraculously when I explain this to them. They say, oh, that's what happens to me. Oh, that's what's happening. The polyvagal theory fits with ACEs in a way. This is by Stephen Porges, and he talked about the nervous system. Most of us learn in basic physiology in high school that the first thing when you're stressed is you go to that sympathetic fight or flight called mobilization. That's not the only thing that happens in trauma, and 75% of my practice is trauma, PTSD. It's not the only thing that happens. The nervous system mobilizes. When we can run, when we can get out of it, we do that. And what do we do at night? We mobilize by thinking and thinking and thinking and thinking. But when there's no escape, when we can't go anywhere, we activate, somebody already mentioned this, the dorsal vagus. It's an archaic reptilian vagus nerve. It's parasympathetic. It's not sympathetic, which causes us to shut down. And we freeze, and we become like the possums, the rodents. I read a study that said 40% of mice in the wild immobilize, and that's why they die. I don't know how they did that study. Did they have little monitors on it? But what immobilization is, it's not sympathetic, it's parasympathetic, and that vagus nerve goes to your subdiaphragmatic organs and causes your whole digestive tract to shut down. It goes to your heart, and it drops your heart, and it drops your blood pressure. So people can have PTSD from pain, trauma, pain, and their blood pressure is not high. They're not the high stress, anxious people that you see. They could be the flat or affect. We can get into, we don't have time for this conversation, but how fibromyalgia, chronic fatigue, and a lot of other chronic pain syndromes are not sympathetic activation, but more immobilization. And so what we want to recruit, and I think all of what we're talking about with healing, is the ventral vagus. It's the purely mammalian vagus. It's a parasympathetic nerve that goes to the heart, slows it down. And Porges calls this the social engagement system. And I love to say that we all know the social engagement system. And if you know this, you know all the mind-body techniques you could possibly do. What is the social engagement system? It comes out of the nucleus ambiguous, and there's the ventral vagal complex. There's 5 cranial nerves that go there. But what does this mean? The example I give is 4th of July. My cat, Jake, he hears the firecrackers and all that annoying things go off. And what does he do? He runs under the table. And he gets under the table and he's meowing and meowing. You know, what you don't do is say, Jake, get out here. It's safe. It is safe, sir. I am telling you, stop. You don't do that. Think about health advocacy. Think about doctors. Think about how we relate, how we talk to people. You go, Jake, you're driving me crazy. I'm going to kill you. Come on now. And you do that. And what did you do? You regulated your voice. You regulated your breathing. You regulated the muscles of your face. We can talk about how that's cranial nerve 5, 7, 9, 10, and 11. But we don't need to get that. But we do these things. And that's the most important thing. We hear about how the patient-practitioner relationship accounts for so much in healthcare. Listening to the story. It's the patient. How we relate to people is social engagement. And it's this regulation. You know, like when you're talking to your teenager, I don't have them. I just have a niece. But, you don't say, really? That's stupid. You're going to show me that sign now? No. Yeah. It doesn't work. What happens is the person stops relating. And when you want to have the difficult conversation with anyone, you say, really, you want to show me that sign? I only have that much time? Okay. these are the things, so that's why I wanted to talk about this, that what happens is our nervous system becomes hardwired. Some people don't like that, but the word hardwired because they think it means from birth. But what it means is it's like handedness. Any skill that you learn, you grow those muscles, the nerves that fire together, wire together. And the more those wire, you get into a habitual pattern. A lot of times I think people are anxious or depressed just because of their posture. And why? Because we all have these favorite devices we're glued to, and we can't breathe. And breathing affects the vagus nerve, and we could get into all the nerves that are involved. So it's not this weird, nefarious thing. All these treatments from years and years and years ago really have some scientific basis. So it's hardwired, and we learned it, and it was adaptive at one time. We held our breath when someone was yelling at us when we were kids, because we don't want to make noise, and we don't want to, if you don't stop crying, I'll give you something to cry about. Oh, I can't tell you the number of people I've heard say that. And so that becomes hardwired and adaptive to help them survive. But then when they're 65 and sitting in my office, this patient who was 65 and had a recurrence of cancer said, I'm afraid to cry because I don't know if I'll cry right. And that's what he really felt, and he was afraid. So this whole thing about, going back to this one, everything is about safety in this language. And I heard this morning. It's all about safety. It's not just, oh, life-threatening safety. It's like this pain. Can I tolerate it? I don't think I can tolerate it. It's not safe. My identity is called into question. That's not safe. Any of this can become an issue of safety. And my patients all laugh at me when I say the word safety, and then it makes sense that when I responded this way, it's because of safety. I'm going to fly through this really quickly. These are each a class in itself. But the way I do this at Bastyr Center for Natural Health, there are so many mind-body techniques. And we categorize them in about 6 different families. And so some people, when they are triggered, I'm just going to use that word triggered. I don't want to say traumatized, triggered. They affect their posture. Sometimes you say something and you can see that they adopt a posture. For people for whom that's the main thing, now all of these are happening at the same time, but for people whose posture mainly gets affected, mind-body techniques like therapeutic exercise, yoga, is really helpful. Now, of course, when you're doing yoga and therapeutic exercises, you're breathing. Some people, when they're stressed or triggered, their muscles tighten. And how do you know? I ask them, how do you know you're stressed? And they go, oh my gosh, my TMJ, oh my neck. And they'll tell you if you ask the right questions, and you have to be listening. The mind-body technique, it's in another slide, it's on the next slide. The mind-body technique that really is beneficial is progressive muscle relaxation. And then breathing, I think everybody has a breathing problem. Because you can do breathing in all of this, and that's what I spend most of my work doing. But you can teach them breath work. And I have said at all the conferences I ever speak, if anybody has essential hypertension, not related to any medications or other conditions, you don't need medications, you need to learn how to breathe. Okay. Stress body focus is a different thing. Stress body focus is when an individual is triggered and they feel their sensation and they focus on their sensation so much that it intensifies. Often we see this in IBS or other chronic pain syndromes. They feel the pain, and as we heard earlier today, when you're talking about the pain gets worse. When you're talking about your cat, which is what the VA hospital uses to help people get into different heart rate states. Think about your dog or your cat, and then they get into this aspect where they smile, they breathe differently, if they like their dog or cat. So stress body focus is where you're focusing on the body, and the mind-body technique for that is called autogenic training. It's a form of self-hypnosis. It's very specific, and if you have questions, I can answer that later, because I have less than a minute. Stressed emotion, stressed attention. I just want to cover that for a moment. Stressed attention is the easiest one. Stressed attention is where your mind, if you're a mobilizer, races, like how fast I'm speaking. Your mind races all the time. You're always trying to solve the problem. An immobilizer would just go blank. I'm reading the same thing over and over again when they're triggered. Stress emotion is really about imagery. It's about a whole person imagery. And I'm just gonna, a stop sign, I don't know what that means. I'm from California, we just drive through. And stressed emotion is where when something gets triggered, they see the end result. The example that I'll say was with my medical students. I say student loans to them, and somebody says, I see myself living on I-5 at the Overman. So they go from 0 to 60 and have the image. So that means you could feel the pain, and you see yourself paralyzed. That's stressed emotion, not necessarily. The mind-body technique that is best for that is really guided imagery or loving kindness meditations. I have other things that I'm not going to get to talk about right now. Yeah. I wanted to talk about some other things like visualization, but if there's other questions, you can ask later. Oh. Awesome. Okay.
I'll try to pick up where you left off, I promise. Hi, everyone. Okay, I have a pinching problem. Here you go. There you go. So, where is that? I'm going to skip this slide because that's just my back and yeah. But I came up with a way of teaching yoga, and I was just joking during lunchtime that I hope I'm not going to bore everyone to death, because in a way we're going over the same thing. Notice everyone is saying the same thing, it's slightly differently, so hopefully our result is that you go home with something. And I'm going to tap into visualization, mindfulness, and breathing while I talk about yoga. So these are my favorite men in my yoga class. I like showing this because a lot of times people associate yoga with females, and that's because of my pet peeve that yoga is, I'm sorry for the word, getting bastardized a little bit with, well, if you can make money off of it, then it's going to be all about the young and the sexy girls putting their legs behind their neck and putting it on Instagram, which is not what I teach, and that is not what's healing. Okay, you have to find the right practitioners and teachers. Notice that I pulled everyone out of the extreme poses. So everything is all about balancing stabilizer muscles and actively stretching, as opposed to dumping into hyper flexibility, which happens quite a bit in yoga classes. And I go off of this idea, what we already talked about, you brought it up, is that the posture influences your mind, and your mind influences your posture. So just for the second, just to put it into your gut, so to speak, hunch down for a second for me, would you? Right? And then just notice how that affects your lung capacity. And if you would stay like this for a long time, what kind of stuff would come up? Okay? I can't leave you here because I got 10 minutes, and even though that Kristen is in my yoga classes, I can hold her in push-up. I don't think I can hold her for that long. Now stand up for a second. It will feel good anyway. It will wake you up. So stand up, and now do one of those, like a little bit, shrug your shoulders and release the shoulders down. And take a couple of deep breaths. And now notice your mind. Okay, you can sit down. Here's the sticky wicket. The sticky wicket is that the body and the posture influences your mind, but your mind is the overrider. You could be standing tall, but I think a few of you maybe felt good breathing, and then some of you were thinking, oh my goodness, did I feed the dogs in the morning, or was I too much in a rush? Are my quarterly taxes? Oh wait, those are my thoughts. Never mind. But you know what I mean? So your thoughts can sidetrack the body movement. And what I like to think about the mind as a stage, and when we are in pain, your wants and goals and needs and desires and attachments, in other words to say, I don't want to feel this, I don't want to be in pain, what did I do to deserve these, I'm not good enough, these things heighten up. And no matter where you are in your body language, you know, you could be in a warrior too, if your internal languaging is such and that there is nobody to lead you towards a better languaging, which is why I said language is so important, then you're still just habitually, remember neuroplasticity? What is neuroplasticity? Yeah, habits, right? Habit forming in a way that's like a shorthand. I know that's not exactly accurate, but we get the idea. If your thinking is still on your old habits that focuses back on a pain or focuses back on the thought that's, I don't believe in negative and positive, that's not productive, then you're still not really practicing yoga the way I understand it, okay? A good teacher is able to guide you in a way during exercise with very few words. And it takes a long time because you can't just kind of get all this information onto your students in one sitting unless it's an informational workshop. You slowly but surely get it to them through teaching them to breathe. And my opinion, the reason why we breathe is, like Brad said, it helps us to relax, but it's more, right? It will give your frontal cortex time to catch up with your emotions, right? Because we all experience that. My mom was really good at saying, before you tell me anything, take a breath, right? Because when you have a teenager, that's a good thing. Your emotional brain is always going to be a little bit faster. So the breath helps you pause and actually process what's going on. It teaches you to wait, right? It teaches patience. It also teaches you that you can only focus on one thing at a time. So if I'm putting people in warrior 2, I can say, feel your feet, now feel your fingers. And it's amazing, they'll slowly notice, and I'll point it out, that really to truly focus means that you are paying attention to one thing. There's no such a thing as multitasking. That has been the worst thing that we adopted into our popular languaging. It doesn't work. It leads to a lot of frustration. It allows for the recognition of emotional states. Kind of like Brad said again, so many of us don't even know how to feel. And emotions are really, really complex. And I teach a class on emotional complexity because often when we're angry, you know, we're really sad. Grief is often anger, right? Grief can also be mania, or it can be numbness, right? We are not very good at knowing how we feel. Breath can help with that. And it eventually teaches you to stay with the discomfort longer. So I don't like saying that yoga is relaxation, because if you look at the Yoga Sutras and you're truly studying what yogas were, they put you in difficult position in order to ask you, can you find a way through anyway, right? So take your arms out, just make sure you don't slam someone in the face. And now I'm going to ask you to relax your shoulders down, but keep your arms out with intention. And just feel the fingers, and then if there's intention but not tension, can you feel the qualifying difference? Intention but not tension. And now see if the breath, if you take a breath, if it's big enough, it's going to lift the diaphragm, and it will extend your abdominal muscles, and you might be just lifting your arms with your breath. I don't know, is that possible? And now go back to relaxing the shoulders. And now notice if you're clenching your jaw. Okay? And if I would do this for you for 5 more minutes, you will definitely have a strong sensation where you have a profound respect for ballerinas all of a sudden. Okay? But that is yoga. The meaning of yoga is actually hatha yoga. Hatha in Sanskrit is not sun, moon, whatever. That was the 19th century reinvention of the language. It means force. It's to force the mind to adapt neuroplasticity and new habits. Okay? So what I do as a teacher when I teach yoga, and this is something that you can take home, right? You can take home the breath. This is a simple thing that you can remember. It's called RAIN. You teach your students to recognize. The breath is there as an anchoring device. Recognize what's going on. Allow enough time for your frontal cortex to take a moment to what is going on. Investigate. Socratic method. We're not so different from the East and the West. All amazing teachers have been saying the same thing. You gotta ask questions. Do not believe yourself. How do habits form? Because you believe what you think, right? The number one thing that the yoga teacher is telling you is to shake you out of your comfort zone and start doubting your own thoughts. That's how you trigger neuroplasticity, and it takes a long time. And then the nurture and redirect to a productive outcome. So I really try to make sure it's not positive, it's not negative. Without anger, women wouldn't have had the vote. Okay? Without anger, Gandhi wouldn't have done what he's done peacefully, right? What do you do with anger? It's telling you that some injustice is happening to you. Take a breath, allow and investigate, ask questions. What is a productive outcome? Yelling is not, right? You channel all emotions. Evolution wouldn't have given you all these beautiful emotions if they wouldn't be all useful. You want to learn to channel them to a productive outcome. So in yoga, what I teach my students is through yoga poses, the byproduct is they get beautifully strong and awesome, and they keep coming back because, we like it. But what I am really interested in is that through the yoga poses, I get to ask them questions to get to know their mind. Through postures and breath, they get to actually rewire their mind and the way they're thinking. So it allows for a different perception of sensations, okay? So why we're in a perfect storm, and there's a beautiful book just published as well, that thing from the 80s that I'm okay, you're okay. Worst thing I think that came out of the 80s. There are a couple of other things, but it's okay to be not okay. It's okay to be not okay. And we don't have to mask it. We don't have to make it pretty, right? Because I said that in my introductory lecture, we're chasing happiness. We're chasing how things look so bad, and then it leads to burnout. And it also leads to unhappiness. You want to be unhappy? Chase happiness. Any moment, I'm willing to bet you, if you recall any moment in your life when you were truly happy, you were lost in a moment and you were not thinking about being happy. It was just in a beautiful... So we're in a perfect storm because though we have this beautiful awakening, I'm teaching mindfulness and this washa is happening, but at the same time we have Instagram and social media. And we have a little bit of Botox, but now women are starting to look like, we have the placid look of everyone because we tend to take everything to the extreme. So on one hand, we have self-acceptance, and on the other hand, we're putting more and more pressure on ourselves to conform. So we are in a perfect storm. And I'm just going to close that as a health advocate, do your research to figure out what is the right yoga studio. And I didn't want to make any yoga studio bad because that's, you don't poo-poo on your competition. I believe that's bad ethics. So I used pictures of myself in both. But there are yoga poses that are clearly not for your healing body. That's me in a firefly position. And there are yoga studios that are nothing more but competition and acrobatics. There's nothing wrong with that. If you're 19, you're going to eat it up, that's great. I do believe eventually your body is going to break down, but that is not yoga the way I like to understand it. There are responsible, great yoga teachers out there, and that's, us falling out of the pose. I always joke, fall, it's the most human thing to fall. If I'm teaching you how to balance in one leg, of course you're going to fall. What else are you going to do, right? So to teach yoga is to teach self-acceptance and to teach that you're okay when you're not okay, and you teach awareness. And so as a health advocate, go and hit the yellow pages. No, we don't do that anymore. Find the right yoga teachers. They're not created equal. And then find the right amount of, there's yin yoga, there's active yoga. Look at your patient, are they mobile? And then find the right yoga style for them as well. And I'm right on time. Thank you. Sorry. All right. You got it.
Now we are transferring to the biologics, right? Ingestible, smoked or otherwise. Garth can introduce himself, but he's serving the VA. Thanks.
Oh, yeah. Hello. So I'm going to speak a little bit about cannabis and also the endocannabinoid system. And just for disclosures, I don't have any relevant financial disclosures, and the views I'll be presenting today represent my own and not of either of my employers. And cannabis, which I'll be talking about, is not FDA approved, and it remains a Schedule I substance, so it's federally illegal, even though there is a retail cannabis market in Washington state. So what I'm going to review today are some of the primary components of where cannabis acts in the brain and the body. We call that the endocannabinoid system. And understanding some of the potential benefits and some of the potential risks and potential harms of cannabis. Because I think that when we talk to patients about their cannabis use, particularly for something like pain, it's really having a well-informed discussion of the relative benefits and risks. I think if you come at it as a complete benefit with absolutely no risk, you're doing a disservice to patients, because there are risks that we know of are really well described. And if you come at the other angle with there's only harms, we have that really well researched from a lot of federally funded studies, but without the potential benefits that they're going to be looking online and asking their friends and going to the cannabis shops and asking about, then you're not really setting them up for potential success in thinking about this appropriately. So I just want to kind of have a show of hands. How many people know a patient who uses cannabis for some reason or another, right? So this pretty much affects pretty much everyone in the room. What about patients who use cannabis for a potential beneficial reason, like for chronic pain or for some other kind of medical condition? Again, so almost everyone. And how many people have seen an advertisement or some kind of discussion or product that's available on the market that includes either cannabis or cannabidiol or something, right? So very, very popular, right? So I think this is a very relevant topic. And this isn't something this is new. Cannabis has been around with humankind for thousands of years, and it's really been only about the mid-1800s that Western medicine kind of got back in touch and discovered cannabis, and it became part of the American Pharmacopeia even into the early 1920s, around early 1930s, and then up through 1974. And it was essentially made illegal in the United States, and that's the status it's been on a federal level ever since. And when I refer to cannabis, I'm really referring to the plant that's described here in the picture. So cannabis is pretty striking, pretty well recognized, sort of finger-like serrated leaves. And I prefer to use the term cannabis because it's both the scientific and medical term and not marijuana, which is really more of a slang and racial kind of connotated and slurred term. Cannabis is grown often in large cultivar grows. This is a grow house in the back of a medical marijuana, medical cannabis dispensary in Southern California. And it's generally grown either inside or outside, but grown for its prized bud, sort of flower form from primarily from the female plant, and then it's cured and sometimes repackaged into individual glass jars, which is done in California and Oregon. In Washington state, there's a law, any individually sold cannabis product has to be individually wrapped and labeled. So they're actually, each bud would be wrapped separately in Washington state. And then some of the buds are processed even further into either edible products like goldfish in the lower right, or peanut butter or chocolate, or syringes filled with cannabis oil extracts, or sublingual sprays in different kinds of forms. And if you haven't been into a cannabis dispensary in Washington or any other states where it's legal, I do recommend it, if nothing else, as an exercise, just to go in and see what's there, what are patients asking for, talk to the person behind the counter who is going to be talking to your patients, what information are they giving them about cannabis if you have a specific question. In Washington state now, cannabis dispensary, they call them bud tenders, but the retail shop vendors are supposed to have some kind of training in being able to talk to patients. They can't diagnose anything and they can't give any specific medical advice, but they should be able to give some advice about appropriate use of cannabis. And but unlike bartenders, they can't cut someone off necessarily in the same way that someone who's intoxicated would be. So what is it that's active in cannabis? And so there are these compounds in cannabis that were discovered kind of particular to the cannabis plant, and so we call them cannabinoids as a result. And the two most common that we know about are up here on the slide, tetrahydrocannabinol, or THC as we generally refer to it, and cannabidiol. And you can see that they're very structurally, they look like very similar molecules. And in fact, the plant has a competitive process in making one or the other. So generally when cannabis is grown, it's either a high THC or a high CBD, or if there's some product that has both THC and CBD in it, it's probably because someone took apart different plants and put them back together and kind of got that ratio of 1-to-1 ratio of THC CBD, which I'll talk about coming up. But you can see the other chemical striking semblance for those who've had some chemistry background. You see that there's this hydrocarbon tail, as we call it. This is a very lipophilic or fat-loving aspect of the molecule. And so this confers cannabinoids as having a long period of acting in the body because they're absorbed in the fat stores and can stay there for quite some time. But these are just two of a host of other cannabinoids that we really don't have a lot of understanding about. And some of these have been proposed as anti-inflammatory or anti-anxiety, but we don't really have a lot of information on it. The research is still kind of scant, and we're just touching the iceberg, the tip of the iceberg, that is. And so when we think about what's being consumed in cannabis, we generally distill that discussion into THC and CBD, but really there's a lot of other compounds, and even apart from the cannabinoids, other compounds that are being consumed that could be affecting one's health. So where are these cannabinoids acting in the body? Well, to dispel the myth, we haven't evolved in order to consume or smoke cannabis, as some people might advocate. This is a part of a plant that has interacted with something in the animal world and the human body that kind of hijacks and interacts with that system, kind of like cocaine interacts with parts of the dopamine system, right? So cannabinoids interact with what we call the endocannabinoid system or endogenous cannabinoid system. And the two main endocannabinoids that we know pretty well described are anandamide, which comes from the Sanskrit word meaning bliss, and 2-arachidonyl glycerol, which was co-discovered by a researcher here at University of Washington. And I'll talk to you a little bit more about what these do. But again, these are just two of several other endocannabinoids that have been discovered, but we don't really know exactly what they do again. This field is relatively young, and compared to nicotine and morphine from tobacco and opium, which those were really kind of isolated and discovered in like the 1800s, cannabinoids weren't really isolated until about 1960 in the receptor system and everything, not until 1990. So this is why I say we don't really know very much yet. The science is still relatively young. So what are these endocannabinoids doing in the body? And there's a lot of different roles that they play, but I'm going to give you kind of what I think is the most salient aspect of it here. And we're going to talk about the nervous system. We've been talking about things like neuroplasticity and the CNS and the nervous system. And so imagine here, it's on the slide represented on the left, a presynaptic neuron. That means that it's the one that's generating a signal to talk from one neuron to the other. And on the right side is the postsynaptic neuron. The synapse is the space that divides the two. And generally, when there's a message that stimulates the release of a neurotransmitter, the presynaptic neuron releases that neurotransmitter, and the postsynaptic neuron gets that signal and says, okay, I'm going to do what that neurotransmitter told me to do. But then there's an on-demand release of this fatty acid-derived compound, the endocannabinoid, that goes back across in a retrograde fashion, backwards fashion, back to that first neuron, and it binds with a cannabinoid receptor. And that receptor tells the primary neurotransmitter to slow down its release. So we can think about in an evolutionary process where if you have neurotransmitters that are being released in excess, and it can become toxic if they're too high in concentration, we need a way to regulate the release of that neurotransmitter. And so the endocannabinoid system acts as like a dimmer switch. It kind of helps to control the release of other neurotransmitters in the body and in the brain. And if we think about neuroplasticity, is one of those topics that have come up earlier. If anyone ever heard of the phrase neurons that fire together, wire together, right? So if these neurotransmitters are causing these neurons to talk to each other, they're firing together, they're going to wire together, they're going to strengthen their synaptic processes and their circuitry. The endocannabinoid system can also help to facilitate that process. So if we interfere with that, like giving plant compounds or cannabinoids that sort of non-discriminately kind of blanket all these cannabinoid receptors and disrupt that neurotransmitter signaling, you're going to disrupt some of that plasticity, which is one of the reasons that in developing brains that are undergoing a lot of plasticity formation, cannabis can be particularly harmful. And then I won't speak to this much here, but if there's questions, I can field them later, that these endocannabinoids are also gobbled up by enzymes that degrade them and recycle them. And some of these enzymes have been targeted as potential targets of action for new drugs for chronic pain that are in clinical trials. So where are the cannabinoid receptors in the brain? So myself and some of my colleagues back at the National Institutes of Health and a couple of other collaborators designed a radioactive drug that was like a cannabinoid, but not exactly like a cannabinoid. And we injected it into volunteers, and we imaged where the cannabinoid receptors are throughout the brain. So this is a PET scan. This is different from a PET scan like you would see for like a cancer patient where there's FDG uptake, which is looking at glucose utilization. Here, or sugar consumption. Here we're looking at cannabinoid receptor distribution throughout the brain. So it's throughout the entire brain, even in the brainstem, throughout the brain cortex, and it's in such high density. It's about as high density as dopamine receptors are in the densest areas where dopamine receptors are found. So this is a very, very highly dense and highly expressed receptor system. What about throughout the body? As you can see here, this is again that same radioactive drug, and we injected it into individuals, and in the first couple of minutes, it got into the vein. It's very lipophilic, remember, so it's kind of sticking. It's very sticky to the veins here, and it actually persists. And it goes through where blood flows, like in the kidneys and the heart and the lungs. But it goes in the brain and it sticks in the brain. And sure enough, that's where the predominant density of the CB1 receptors are found. But also in the bone marrow, you can start to see some areas of bone marrow in this skeleton here. And then this drug is metabolized in the liver and excreted through the gallbladder. So that's partly where CB1 receptors are, but also partly where it's metabolized. So CB1 receptors are found mostly in the brain, but throughout the entire body, and also the other nerve endings and nociceptive nerve endings and dorsal root ganglion, which are the back of the spinal cord. Some of the beneficial effects of cannabis are THC and cannabidiol. So these are a list of potential beneficial effects of either THC or CBD as are listed. The ones that I've highlighted in red are the ones that have considerable, and we would say probably good evidence that they're potentially helpful. And some drugs have been made that are either synthetic versions or sort of altered versions of either THC or CBD for some of the ones that are highlighted in red. The ones that remain in black are those that have some clinical trials or small studies have shown that there's some benefit, but that amount of benefit probably doesn't outweigh the risks that are associated with it, or we just don't have enough information about it yet. So some of the potential benefits, nausea, and increase in appetite, specifically for people who are undergoing chemotherapy and may have nausea and decreased appetite from result of that. Some analgesia, I'll talk more about that in a moment, and with cannabidiol, anticonvulsant. Pain or analgesia for cannabidiol is a little bit mixed. There actually haven't been any large clinical studies looking at analgesia and cannabidiol to date, but that doesn't mean that there's no effect there. It's just that we don't really have the information, and I can talk more about that during the panel if there's questions. What about some potential harmful effects? This is a non-exhaustive list, but ones that I think that are pretty salient and worth reviewing. So cannabis, and when I refer to cannabis, most of the adverse effects probably are attributed to THC, but some of it may be associated with the smoked tar or smoked particles that are resulting from smoked cannabis or from other cannabinoids that are not as well separated from study. So anxiogenic, meaning it creates anxiety. Oh, I'm running out of time. So I'm just going to highlight a couple here that are particularly important, which is impaired cognition, judgment, and potentially increased risk for psychosis and an increased risk for heart attack. So I'm just going to touch briefly upon a couple of studies looking at cannabinoids and pain, and then I'll take any questions with the panel. So overall, cannabinoids seem to help with the unpleasantness of pain, but not the intensity of pain. So if somebody is using cannabis for pain, they may still feel the sensation of the pain, but they're less bothered by it. They're less affected by the affective version of the pain. And it seems to be helpful for the type of pain that's experienced that's generated from injured or sick nerves themselves, not from an acute injury, which we call neuropathic pain as opposed to nociceptive pain. And what kind of ratio should we be thinking about in terms of what's effective for pain? In a study done in the Netherlands where they looked at a primarily THC and a primarily CBD and a 1-to-1 ratio, it was a 1-to-1 ratio that outperformed either one alone or placebo, but only in those who had a 30% reduction in pain. It doesn't really have a profound or 50% or greater reduction in pain, and it's really with the 1-to-1 ratio. So just to draw up some conclusions here, cannabis may be helpful for pain, but I wouldn't recommend it as the most effective treatment, and a cost-effectiveness study has shown that as well. A 1-to-1 ratio would be more effective probably than either THC or CBD alone. I didn't really speak to it much, but it was listed on a slide that the pain and beneficial effect of THC is generally much lower than that causes any kind of psychomimetic or euphoric effect. So there are some doses on here that I can speak to that more. I think that's a little bit of a sort of a gray area at this point in terms of our understanding, but we do know that CBD might be helpful for inflammation and potentially anxiety associated for pain. There's research underway looking at that. And as I mentioned, cannabis can be helpful for the experience, but not the actual reduction of pain itself. But I wouldn't recommend individuals who have pain with mental illness, like depression or psychosis, be using cannabis, because I think there the risks are really going to outweigh the benefits by and large. So anyway, I can leave the rest of my time and take questions. Forgot I was attached here.
So as we get the panel set up, and I'm getting plugged back in here, I'm going to ask a couple quick questions of the panel, and then everybody get ready with yours. And I'm going to try to ask questions that you may be wondering. So, Garth, how does one assess whether a place that sells cannabis is a place they want to go into? Do you have a one-line answer to that?
Two recommendations in terms of if you really want to have a good sense of is cannabis going to work for pain. Recommend looking at clinicaltrials.gov. There is more research going on right now in terms of cannabis research. I wouldn't be surprised if you found a clinical trial going on at the moment. And the other would be for a patient that goes into a dispensary and they find something that really works for them for their pain, to stick with that. Stick with the same product, stick with the same dispensary, because there's a lot of variability in the product, even from the same strain, like quote unquote strain or name of the cannabinoid product that's out there, and different growers. It can change with the water exposure and the fertilizer and all sorts of variables. And so if they find something that works, try to stick with that as much as possible, as long as the side effects are well moderated.
Brad, my advocate question is, can people refer to you directly? Is there a pain clinic at Bastille?
Yes, and yes.
Okay, I like that. All right, so you know where to find him. Okay, and Dora, you were very politic about not, are there any simple questions if an advocate called a yoga studio they might ask to get a sense as to whether this is a place that they would want to send somebody? Or do you just need to go visit or get to know your local people? Any advice there? Okay, that was even a quicker answer. While she's contemplating, any questions?
So I got some. I would stay away from any studio that's extremely hot. Generally speaking, there's always exception to the rule. Generally speaking, extremely hot studios tend to be all about lose as much water weight as possible and beat yourself up. Most studios that work on mindfulness have no mirrors. That's also not 100% rule, but definitely a studio that lacks mirror tends to be more on internal reflection.
Okay.
And then look at the teachers and see that their description is more than just posturing.
Okay.
Yeah, so
Excellent.
it's more than just asana.
Excellent tip. Any hands? There's a mic right here for questions. Any questions for the group?
Can I add something to that?
Absolutely.
So
And
I
here's the
just-
question. Good.
Years ago, I developed a course sequence on yoga therapy at Bastille. And so my friend, I won't say her nickname, probably the yoga something, but she and I went to different yoga studios. This was about 10 years ago, so there were different ones around the city. And we went to one every week and then had brunch and deconstructed it. It was so interesting because we would fall out of poses and we would laugh. And we'd look around, especially the ones in certain neighborhoods, and they would all be like, why are you laughing? And it's like, so I think you should, if you could also visit, you'll find out a lot.
Be able to laugh. Okay, laughing.
Yeah,
laughing.
laughter.
If they don't
Okay.
laugh, don't go.
Yeah. Questions. Here's a question.
I have a question for Garth. Guide us in how, if I have an elderly client and wants to try CBD for sleep, they're not sleeping. A lot of elderly people just don't sleep, but they heard it was a good thing. What do I tell them?
Yeah, so there haven't been any large studies looking at CBD for sleep specifically, but CBD is essentially a non-psychomimetic cannabinoid that's actually supposed to include even drowsiness or sleep. Studies that have looked at really high doses, like for seizures or for other conditions, which are like 800 to 1,200 milligrams of CBD, which would be about $75 to $100 per day if you were to buy it on the market, have had a side effect of increased somnolence. But that may have been actually an effect of a drug-drug interaction with another medication. So CBD probably isn't really that effective for sleep. Now, THC has been studied in individuals with Alzheimer's disease and is found to be relatively well tolerated at about 10 milligrams a day, which I would consider to be a moderate to high dose, particularly for somebody starting for the first time. It's something that helps to reduce the latency to sleep, so someone falls asleep faster, but they might not get as much restful sleep overall because it actually prevents getting into what we call REM sleep, which is the restorative sleep. But other studies have shown that actually might be a little bit less so than other sleep medications that are out on the market. So it's something that I think would be, as long as there's no other relative contraindication, something to think about, but probably THC rather than CBD would actually be probably better for sleep. If there's for something for pain and sleep, then I would say really something that includes a 1-to-1 ratio given the data that's out there.
Okay, Yo's got the.
Yeah. Hi. I have a question about how does somebody go about getting the right type and the right dose as a patient, or how are we to advise these patients as advocates if they're not to do it on their own? Many people are actually wondering, they come to us and they have asked us a couple of times, is there a physician that can prescribe this? Or a physician that can guide me and oversee this? Is there an answer to this question?
Not a good one. So in a public survey of patients who have been wanting to get information about cannabis and cannabinoids, a lot of them have said that they want to get information from their healthcare provider, but healthcare providers have said they don't feel like they're educated enough on the topic to really give them good advice. The medical cannabis state in Washington has essentially been outstripped by the retail market at this point, or quote-unquote recreational use. And so there's, I think, the knowledge and sort of thoughtfulness going into medical use of cannabis is actually maybe starting to wane a little bit on that side in terms of the retail. That's just kind of my own opinion. But I think encouraging patients to be open and discussing it with their providers. And then I've included some references in some of the slides that I had here. Providers can always look through the medical literature. There is a growing amount of evidence about what can be helpful and what are some of the risks involved as well. So I hope that answers. I know it's been that
And I'm so sorry. I've been told to wrap up. Okay. And the wrap up, yeah, I know. We're going to have to put that on your comment sheets. But I guess the wrap ups is really pretty simple. Pain's complex. There's a lot of variety of things that we have to offer. And it's a challenge to us to now try to learn both about our local community, what it has to offer, as well as the science, and help integrate all this.